everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you so much for joining us this evening. Before we get started, I'd like to take a moment to cover a few quick housekeeping items. For those of you who remain online for at least 75 minutes, your CE certificate will be emailed to you within hours of this presentation. Please be sure to check your spam folder just in case it ends up in there. Everyone is currently muted, so there's no need to worry about background noise during the session. We will have some time for Q&A at the end of the presentation, and you can submit your questions via the webinar dashboard as we'll be tracking them throughout the talk. We've hosted an extensive series of free live CE webinars on a variety of prevention topics. These webinars are recorded and available for free self-instruction CE at the website you see on the screen, elevateoralcare.com/elevatingcare. Be sure to bookmark the page and check back often for new CE opportunities. If there's a specific topic you'd like for us to cover in a future webinar, feel free to send your suggestions to info@elevateoralcare.com or complete the webinar survey that will be sent to you after this evening's session. We love receiving your ideas and often design our webinars based on your feedback. Tonight, we are thrilled to be joined by Dr. Jasveen Singh and Dr. Daniel Jurgens. Dr. Jasveen Singh is a pediatric dentist and owner of Pediatric Dentistry and Beyond. A member of the American Academy of Pediatric Dentistry and the Alliance of Independent Dentists, she is dedicated to advancing children's oral health through compassionate, family-centered care. In 2024, she was named one of America's top 40 under 40 pediatric dentists by Incisal Edge magazine for her clinical excellence, innovation, and community impact. Her expertise on children's oral health and modern dental care has been featured in national outlets where she has been quoted in publications such as Babylist, Oravix, Single Care, AOL, and Yahoo. Dr. Singh brings both skill and passion to her work, making every dental visit a positive and educational experience for patients and their families. You can follow her on Instagram at smilewithdrjazz, where she shares videos on the latest things concerning pediatric dentistry. Dr. Singh, thank you so much for being here this evening. Our next speaker is Dr. Daniel Jurgens. He is a general dentist from Decatur, Illinois, who is passionate about cariology and advancing oral health through the medical management of caries. He is part of the Canberra Coalition and regularly seeks to discover innovative ways to treat caries disease. Dr. Jurgens is a graduate of the Foundation for Advanced Continuing Education, FACE, levels 1, 2, and 3. He is the immediate past president of the Decatur District Dental Society and was nominated to join the Illinois Dental Policy Review Committee. Thank you, Dr. Jurgens, for being here. And without further ado, I'm going to turn it over to you. Thanks so much.
Hi, my name is Daniel Jurgens. I'm a general dentist from Decatur, Illinois, who treats pediatric, geriatric, and adult patients in private practice. Today, we'll be discussing how to integrate Papacárie, atraumatic restorative treatment, or ART, silver diamine fluoride, or SDF, and silver modified atraumatic restorative treatment, or SMART, into clinical workflows. My disclosures for the following presentation are that I'm receiving an honorarium from Elevate Oral Care. I will also be discussing FDA off-label use of Papacárie and silver diamine fluoride. Papacárie is FDA cleared to clean a preparation prior to self-etching procedures with resin bonding and used off-label for removal of infected dentin. SDF is cleared for desensitization and used off-label to arrest caries. Finally, I've cropped and lightened my clinical photos. I'd like to thank my assistants, Haley and Kaylin, and my brother Michael for taking the photos. My objectives for presenting this material are to discuss healthy dentin structure and formation, function, and how carious lesion progression changes dentin structure. We will use that knowledge alongside modern findings from the literature to go over indications, contraindications, and clinical steps for using Papacárie Duo, glass ionomer cements, silver diamine fluoride, and smart restorations. Healthy dentin is a composite structure of dentinal tubules, peritubular dentin, and intertubular dentin. The cell bodies of odontoblasts lie in the pulp, and their long extensions pass through small channels in the dentin called dentinal tubules. Tubules provide both sensation and protection through fluid and ion movement. Fluid movement in the tubules triggers nerve responses and allows sensation of temperature, pressure, and chemical changes, all of which are the basis of tube hypersensitivity. Slow ionic movement within tubules produces protective sclerotic mineral plugs and reparative internal remineralization of early damage from within. Around each tubule, highly mineralized peritubular dentin reinforces the tubular walls. The dense mineral in peritubular dentin gives it high stiffness, compressive strength, and fracture resistance. And intertubular dentin makes up the majority of dentin's mass. Now, we're going to focus a lot on intertubular dentin in this lecture. Its dense mineralized collagen network gives dentin its flexibility, kind of like a web of tough tension fibers that absorb and spread out forces from chewing or injury. This built-in shock absorber helps to shield the brittle enamel above and the sensitive pulp below. The role of intertubular dentin is also critical for adhesion of dental materials. So with glass ionomer cements, they bond to the mineral content in intertubular and peritubular dentin. Alternatively, total etch resin dentin bonding systems rely on micromechanical undercuts in intertubular dentin that's been demineralized with phosphoric acid. This again differs from newer mildly acidic self-etching bonding systems, which superficially interact with a modified smear layer on top of dentin. If we were to imagine the contents of dentin in a volumetric container, it would measure on average 23% water, 27% collagen, and 50% mineral. Type 1 collagen is concentrated in intertubular dentin and is composed of amino acids that align into an alpha chain. Protein, 3 alpha chains intertwine to create a unique triple helix collagen molecule. Collagen molecules then assemble into fibrils and fibers. In each collagen alpha chain, glycine appears as every third amino acid in the sequence. Instead of folding into an alpha helix or beta sheet, this regular pattern allows for multiple chains to pack tightly together into a collagen triple helix. The triple helix contains 3 alpha chains and is termed a collagen molecule, or tropocollagen. Each collagen molecule has an N and C terminus called a telopeptide that contributes to intermolecular cross-linking. The triple helix of collagen can be damaged when exposed to acid or heat. Within a healthy collagen fibril, intrafibrillar mineral sits between the collagen molecules and functions as crack deflectors. Extrafibrillar mineral fills spaces between collagen fibrils. Now that we have a general overview of dentin structure and function, we can discuss how caries disease causes carious lesion development in dentin. A critical distinction needs to be made between cavities and the disease that causes them. Caries disease is a chronic disorder modulated by dietary carbohydrates and marked by an imbalance between host and microbes. Acid-producing and acid-tolerating microbes repeatedly demineralize tooth structure, leading to mineral loss of dentin hard tissues. A carious lesion or cavity is the clinical sign or manifestation of caries disease. The medical management of caries, or MMC, aims to treat caries disease at a person level as opposed to just carious lesions restoratively at the tooth level. Caries disease cannot be removed with surgical instruments, but can be controlled by diet, behavior, and medicines. And what we're mainly focusing on this lecture today is the medicine aspect of that. Caries progression in dentin occurs in 3 stages. First, microbial acids dissolve mineral. Next, host enzymes break down the exposed collagen. And finally, microorganisms, including a polymicrobial mix of fungi, bacterial, and archaea, invade the softened tissue. Initially, cariogenic metabolites like lactic, acetic, formic, and propionic acids demineralize extrafibrillar mineral and collagen fibrils. After extrafibrillar mineral has been demineralized, microbial acids target the intrafibrillar mineral. After the first stage's acidic demineralization, the collagen molecules have been exposed. In addition to demineralizing collagen, microbial acids, these organic acids that we just talked about, activate host-derived matrix metalloproteinases and cysteine cathepsins, which are proteins embedded within the dentin matrix. These endogenous proteases destroy the organic matrix by degrading structural components like the collagen triple helix, proteoglycans, and glycosaminoglycans. After the second stage is host proteolysis, collagen has been degraded, and the third stage involves cariogenic microbial invasion into the demineralized, degraded, and softened dentin. The microbes produce more acid, which activates more MMPs and cathepsins, continuing the progression and activity of the carious lesion. Caries infected dentin contains collagen fibers that are both demineralized and irreversibly denatured, with intramolecular and intermolecular cross-links broken, leaving the matrix structurally unsalvageable. Caries affected dentin contains collagen fibers that are demineralized but not denatured, preserving their fibrillar scaffold and allowing remineralization to occur. Healthy dentin retains its mineral content and its crosslinks. One of my favorite quotes is from Falk Schwendicke, and it has completely revolutionized the way I practice dentistry. He states, "The aim of treating carious lesions is to control their activity, not to remove the carious lesion itself." We'll discuss 3 methods to arrest and control the carious lesion activity on vital teeth, given that their pulpal status test either normal or with reversible pulpitis. Atraumatic restorative treatment with glass ionomer, non-restorative application of SDF, and silver modified atraumatic restorative treatment, or SMART, are all ways in which clinicians can treat both the carious lesion and the carious disease that causes it. These are not the only ways, but these are the ways I use most commonly in clinical practice. First, let's focus on atraumatic restorative treatment, or ART. In 2023, the American Dental Association published clinical practice guidelines on restorative treatment for carious lesions. The guidelines recommended selective carious tissue removal for moderate and advanced cavitations in vital and primary permanent teeth. Here is a clinical case involving an advanced cavitated root carious lesion on tooth number 26. The patient was moving to another state and is unable to return for future visits. I like performing atraumatic restorative treatment in areas of higher aesthetic concern and/or when the patient will not predictably return for future treatment. First, clean off the biofilm and pellicle with pumice, and then either rinse it off or wipe it off with wet gauze. Next in the clinical sequence will be Papacárie Duo, a medicine from Elevate Oral Care. It utilizes the enzyme papain from the skin of unripened papayas. Papain is used to selectively destroy caries-infected dentin in a process called chemomechanical caries removal. Chemo, meaning infected dentin, dissolves when treated with papain and chloramine chemicals in the Papacárie gel. Mechanical, meaning that the dissolved infected dentin can then be gently disrupted with a microbrush, hand instrumentation, or a slow-speed rotary burr. And this can usually all happen without any local anesthesia, making the treatment very quick and effective. Place a flowable composite tip onto the Papacárie Duo syringe. Don't try placing an etch tip on it because the lumen's too small for the viscosity of the gel. Extrude Papacárie Duo into the carious lesion and wait 60 seconds for the papain enzyme to work. Here, I used a spoon excavator to mechanically remove the deproteinized infected dentin, and you can repeat multiple times as necessary until infected dentin has been removed. Usually, I don't have to apply this more than once or twice. Alternatively, you can also extrude Papacárie Duo onto your glove or into a dappen dish and apply it onto the carious lesion with a microbrush. At the molecular level, denatured collagen contains exposed alpha chains that are no longer held together in a triple helix. So here's the collagen molecule, and what the active site of papain does is take it in, form an intermediate, break the peptide bond, and after cleaving the peptide bond, the denatured collagen and infected dentin can be easily removed because it's, for all intents and purposes, dissolved. At the level of the collagen fibril, Papacárie deproteinizes the smear layer and destroys denatured collagen in infected dentin while keeping affected and healthy dentin intact. After selective caries removal with Papacárie, the carious lesion is conditioned with polyacrylic acid for 10 seconds, rinsed, and kept moist. 20% polyacrylic acid removes the smear layer, which occurs whenever we use any hand instrument or whenever we use a handpiece. But 20% polyacrylic acid also partially retains smear plugs in the dentinal tubules, keeping the areas desensitized. PAA also retains the high mineral content of intertubular dentin, allowing glass ionomer cement to form ionic bonds with dentin. After conditioning, either a pure glass ionomer cement or a resin-modified glass ionomer cement is triturated, extruded, and swiped with a moist glove finger or a blunt instrument. Try to do all this within 30 seconds after mixing the capsule. If you manipulate past 30 seconds, you risk interfering with the set of the glass ionomer. We'll talk about why that is. During the first 3 minutes, an initial cross-linking phase occurs between the polyacrylic acid chains of the glass ionomer itself and between the glass ionomer and the tooth, which is termed apatite in this photo. This cross-linking is weak and mainly involves hydrogen bonds. The clinical significance of that is that, unlike composite resins, a preparation must be slightly moist to accept the glass ionomer and form these hydrogen bonds initially. So you don't want water pooling, but you also don't want to desiccate or dehydrate the tooth prior to applying glass ionomer cement. After the initial cross-linking phase, glass ionomer maturation involves ionic bonds between polyacrylic acid in the matrix, aluminum, and strontium within the matrix itself as well. And then between the glass ionomer and the tooth, strong ionic calcium and strontium bridges are also formed in an area called the ion exchange layer, or the zone of chemical fusion. This interphase is hypermineralized, acid resistant, and stronger than either the glass ionomer or the tooth itself. To help achieve this maturation, I tell patients not to eat or drink anything crunchy or chewy, or have anything really hot for 2 days at least after glass ionomer is placed. If the glass ionomer restoration is even bigger, I tell them to go easy on it for more days than that. Wait 3 minutes after your glass ionomer is placed and contour any excess off with a non-end cutting burr at slow speed under copious water spray. I like using the non-end cutting burr because I don't ditch the restoration as easily, and I just go in one motion from buccal to lingual, pick it up, go back, go buccal to lingual. If you dry out the glass ionomer, what'll happen is it'll crack and fail to undergo maturation. If that happens, you should take it out and just redo it because it will fail. Always keep the glass ionomer moist after it sets. Now we'll discuss non-restorative application of silver diamine fluoride, or SDF, as a method to arrest cavitated carious lesions. The biggest pushback I hear about SDF from providers is related to black staining. If the therapeutic effects are communicated effectively, the majority of patients have no problem receiving silver fluoride. Words matter in talking to patients about SDF. SDF does not turn teeth black. SDF turns carious lesions or cavities dark. SDF is indicated to treat and prevent carious disease at the person level, detect and diagnose new carious lesions, arrest cavitated or non-cavitated carious lesions, desensitize hypersensitive teeth, reduce gingival inflammation, and as an indirect pulp capping agent on vital teeth. SDF is contraindicated in cases of irreversible pulpitis, necrosis, visible pulpal exposure, or when the patient declines after having been provided the risks, benefits, and alternatives. Silver ions are microbicidal and kill cariogenic organisms. Silver ions also combine with chloride and saliva to form silver chloride. Silver chloride functions as a slow-release reservoir of even more silver ions, which can be reduced by compounds in saliva and dentin into neutral silver particles and nanoparticles that are responsible for the black staining of carious lesions and the tubule occluding desensitization properties of SDF. This also is responsible for the microbicidal and effects that block the tubules. So silver nanoparticles can undergo a oxidation back by saliva into more silver ions, contributing to a long-lasting antimicrobial and remineralizing effect. And those same silver ions can either disrupt the cell wall or DNA replication processes of the microbes themselves, or inhibit those endogenous proteases we talked about, the MMPs and the cysteine cathepsins, to inhibit demineralization. Elevate Oral Care's new SDF gel has been shown to create silver precipitates that occlude tubules in both scanning electron microscopy and three-dimensional microcomputed tomography images. This tubule occlusion both desensitizes and arrests microbial invasion. The 44,800 parts per million fluoride in SDF both remineralize and inhibit demineralization by forming fluorapatite and fluoride substituted apatite. Fluoride ions are also antimicrobial as they inhibit microbial enolase in the glycolytic pathway. Finally, fluoride ions can combine with calcium and apatite and saliva to form calcium fluoride, which is a slow-release reservoir of even more fluoride ions. These two studies were conducted almost 20 years apart and came to the same conclusion. It's unnecessary to remove infected dentin when applying SDF over cavitated carious lesions. The clinical steps in SDF application can be as simple as dry, apply, say goodbye. I've added a few more steps just to reflect what I do clinically. There's no wrong way to apply SDF unless you don't do it on an area that needs it. So the way I do it is, number one, mask the offensive taste by placing something better flavored like toothpaste or xylitol on the patient's tongue prior to doing anything. Number two, isolate the cavity. Number three, dry the cavity. Number four, apply SDF on a microbrush for 15 to 30 seconds. Number five, cover everything with fluoride varnish. Number six and number seven, rinse off the patient's tongue several times and place a more flavored toothpaste or xylitol on the patient's tongue if desired to get rid of the taste. Here's a clinical example of the same case we just went over for ART, where SDF was used after for the indication of preventing new carious lesions on root surfaces. So we dry the roots and the crown margins. You can put something on the tongue beforehand if you want to. Apply SDF on all areas and try to do it for 15 to 30 seconds. If any areas are pooling with SDF, you can blot them with moist cotton or gauze. And then cover the areas with fluoride varnish and rinse off the tongue. Remember, in kids or in behaviorally difficult situations, that even if SDF is rinsed off immediately, 65% of the caries arresting benefit is gained. If you wait 10 to 15 seconds prior to rinsing, you get 80% of the benefit. Covering SDF with fluoride varnish between 2 visits 4 months apart in a study yielded an arrest rate of 96%. So it's unnecessary to tell patients not to eat or drink for 30 minutes after SDF either. That was from a new study that came out last year. Use any flavored toothpaste to help with the taste of SDF after application. In this case, I finished the application and then I reinserted the patient's removable partial denture. Here's a case on the distal of tooth number 15 where number 16 had been leaning on an area prior to its extraction. This high-risk area was accumulating plaque and turned into a low-risk area after SDF application. If the area were to continue accumulating plaque, it would reactivate in time. So in that case, if we needed to, running a burr to get rid of the concavities would help the lesion remain self-arresting. This is something that Graham Craig out of Australia wrote in his book, and it's called the Inger's technique. Hidden or closed lesions are less likely to self-arrest after silver fluoride than open ones. In this case, the lesion was fully arrested after one application and required no further intervention. With this patient, SDF detected cavitated carious lesions and reduced gingival inflammation. However, the cavities were still accumulating plaque after SDF, so they were restored to cleansability with the SMART technique. SMART stands for Silver Modified Atraumatic Restorative Treatment. It can be thought of as potentiated atraumatic restorative treatment. SMART can be performed immediately in one visit or as a delayed technique in 2 appointments. One-step SMARTs are indicated to immediately desensitize, arrest, and functionally restore a cavitated carious lesion when the patient is unlikely to return. One-step SMART is contraindicated when in the same scenarios as SDF, with the caveat that the glass ionomer placed over SDF at the same visit will turn grayish over time like a pale amalgam. So that just needs to be communicated with the patient beforehand. To perform a one-step SMART, clean the lesion with pumice, rinse and dry, apply the SDF to the lesion for 15 to 30 seconds if possible, then rinse and dry it. In my experience, the acidic glass ionomer adheres to the SDF-treated dentin once the alkaline SDF has been rinsed off. I got more debonds of the glass ionomer if I applied glass ionomer directly over the silver diamine fluoride, but that is a technique that can work to arrest the lesion. I then condition the cavity with 20% polyacrylic acid, rinse it and keep moist. And then I like to cover with a pure glass ionomer cement. If you light cure something like a resin modified glass ionomer, the light energy will photoreduce the silver ions into silver atoms immediately and stain the area very quickly. This is not an issue if communicated properly with the patient or caretaker prior, and can be pretty useful in pediatric scenarios. But again, tell the patient not to eat hard or crunchy foods for 2 days after to allow the glass ionomer to mature. This study from Japan evaluated a SDF brand called Saffride and GC's Fuji 9 glass ionomer cement. Immediately after SDF application, silver ions accumulate on the treated surface and migrate deeper into the carious lesion over the next month until they disappeared from the surface after 3 months. If glass ionomer cement was added over the SDF in an immediate SMART technique, the silver ions similarly diffuse throughout the lesion, but remain numerous at the interface after several months. You can see after 3 months how the green strontium from the glass ionomer enhanced the effect of the red silver from the SDF, which in turn enhanced the blue calcium hypermineralization in dentin to heal and seal the carious lesion. The synergistic effect and combination of SDF and glass ionomer increases mineral density of the lesion and promotes remineralization greater than either medicine by itself. Here, you can visualize how the hypermineralized dentin formed underneath the SMART sample after 3 months. This case demonstrates how powerful SMART combination therapy can be. On this tooth, a subgingival carious lesion was treated with silver diamine fluoride and glass ionomer cement in 1 visit. After several months, the lingual cusp suffered an oblique cusp fracture that revealed a completely arrested and asymptomatic dentin that appeared almost indistinguishable from the adjacent amalgam restoration. My preferred way to perform a SMART restoration is through the 2-step or delayed protocol, where SDF is applied at the first visit with 0 removal of caries infected dentin, and the patient returns anywhere from a few days to a few weeks later to receive the atraumatic restorative treatment with glass ionomer cement. The 2-step SMART protocol is indicated for desensitization, arrest, and functional restoration of a cavity when the patient is likely to return and consents to temporary SDF-induced staining of the cavity. I explained this to a patient like we can apply a silver fluoride liquid on your cavity that stops the progression of the decay. But if the cavity keeps collecting plaque, it will reactivate at some point. The silver fluoride lets me remove less tooth structure when you return to fill the cavity. Usually, this technique also lets me perform your filling without numbing and without drilling. The liquid will temporarily stain the cavity darker, but it can be covered up with a white filling when you return. What are your thoughts? In most cases involving smart restorations, you'll notice that not much infected dentin has to be removed afterward. So here's a clinical case involving a cavitated carious lesion on number 2 and number 3. Number 3 was still retaining a small portion of a resin-modified glass ionomer cement base. At a previous appointment, the tooth was treated with SDF and fluoride varnish. And then at the next visit, the tooth was cleaned and pumiced, rinsed, dried, and Papacárie Duo was still applied for 60 seconds. So like I said, you probably will not see much infected dentin after SDF was applied at a previous visit, but I always still like to apply Papacárie Duo just in case there are islands or small bits of infected dentin following the initial SDF application. Papacárie Duo also deproteinizes the smear layer to prepare the tooth for polyacrylic acid conditioning. The dark arrested areas at the base of the old restoration don't concern me if I can still achieve a peripheral seal or parachute of clean dentin to adhere the glass ionomer cement to. Here, I conditioned the tooth, rinsed it, left it moist, extruded the glass ionomer cement, waited 3 minutes for it to set, checked occlusion, and I was done. I've got one more case to share, and I showed this to Haley Buckner at Elevate. She told me that every office would benefit from these types of treatments. They aren't for every patient, but there is a patient in everyone's office or practice who would benefit. This patient had been struggling with cavities for several years due to polypharmacy-induced xerostomia. His main desire was to keep his lower 6 anterior teeth so that he can continue wearing a lower partial denture. Since he has 0 aesthetic demands and does not show his lower incisors during any speech or function, we elected to maintain all lower anterior teeth with SDF and SMART. In this delayed SMART case, I applied SDF to the mesiofacial of tooth number 23, and the patient returned about 2 weeks later for restoration. Papacárie Duo was applied for 60 seconds. Infected dentin was spoon excavated from the peripheral walls. And on a vital tooth that tests either normal or with reversible pulpitis, leaving infected dentin over the pulp is preferred to iatrogenically exposing the pulp. With delayed smarts, you'll notice that Papacárie and hand instrumentation releases black atomic silver particles. These black areas of dentin are arrested, but do not bond as well to the glass ionomer as sound dentin. If the black precipitates remain, clear them from the cavo surface to create 1 to 2 millimeters of sound dentin on the peripheral walls. Once the carious lesion has a wall of clean dentin to which glass ionomer can bond, pumice, rinse, and dry the tooth to remove the pellicle and the biofilm. To achieve higher bond strength to a pre-existing adjacent glass ionomer, I etch it for 10 seconds with 37% phosphoric acid, rinse it and dry it. I'm not etching the enamel or the dentin. I'm just etching the previous glass ionomer. Condition the tooth then with 20% polyacrylic acid for 10 seconds to remove the smear layer, just like we talked about, while retaining the smear plugs in the tubules. Rinse it and keep it moist. Use either a sectional matrix, Toffelmeyer band, or Mylar band to hold the glass ionomer, form and restore the cleansability to the tooth. After 3 minutes of the set time, the glass ionomer can be contoured under copious water spray with a non-end cutting burr. Never dehydrate the glass ionomer during finishing. So usually I'll tell my assistant to either use a slow volume suction like you can see in the photo, or if they are using a high volume suction, I keep it well away from the restoration and always keep eyes on it. You'll see it desiccating like a desert floor cracking. If that happens, that means that you've interfered with the initial cross-linking and maturation phase. Over time, this opaque glass ionomer will become more enamel-like in both hardness and color, just as you can see the restorations on the adjacent teeth are here. I know this is not aesthetic. I truly believe, though, that these are the treatment modalities that are the best way to treat both an active carious lesion in a high-risk patient and caries disease itself at the person level. Revisiting the initial objectives, we talked about healthy dentin structure, collagen, and how caries lesion progression changes dentin structure. We also talked about how Papacárie duo targets peptide bonds and denatured collagen and can be utilized in both atraumatic restorative treatment and in the SMART technique. We went over how glass ionomer cements restore the cleansability and reverse the activity of carious lesions. We talked about how SDF is antimicrobial, remineralizes, desensitizes, prevents, arrests, and detects new carious lesions. And finally, we discussed how combining SDF and glass ionomer, either in a single step or in 2 sequential steps, is a powerful tool for arresting carious lesions and treating caries disease. As Mike Shirtcliffe says, the profession now possesses medicines that treat caries disease and do not require patients to change their behavior except to allow the medicine to be applied. Thank you everyone for your time and listening to this lecture. I hope you have a fantastic morning, afternoon, or evening from wherever you're listening in on.
Thank you, Dr. Jurgens, for letting us know your perspective as a general dentist. I, as a pediatric dentist, will go over my applications with Papacárie. So as you know, Papacárie is a chemomechanical caries removal system. It's made from papain, an enzyme that's made from papaya. It targets only the infected tissue, so it leaves behind healthy tooth structure. It's bactericidal, bacteriostatic, and anti-inflammatory. They have been using this product outside the US for over 20 years and have found great success with it. And the main active ingredient is from papaya, and the other one is chloramine. I have found a lot of great advantages for Papacárie as a pediatric dentist. First of all, I'm removing less tooth structure. You know, with a handpiece, you definitely get out some healthy tooth structure as well. With the Papacárie, I have not had to use any local anesthesia. I find it improves my patient's comfort. Some of the younger children, they don't like the noise of the drill. So using Papacáries as my main way of removing decay has been very helpful. It also aligns with the modern caries management philosophy of minimally invasive dentistry, since it will only take away the infected dentin. I also can restore the same day as using it, and the product enhances the bond strength of the restorative materials. With Papacáries, there's no discolorations or staining. Because of its properties, it doesn't actually harm any soft tissue. So if it goes anywhere else other than the tooth, I don't have to worry about it. I can just wash it off. There's also no specific post-op instructions or sensitivity that my patients face. How it works is the papain enzyme breaks down the collagen in the infected dentin. It softens the carious tissue, so the tissue becomes like soft and leathery, and it makes it a lot easier for you to spoon out the decay. And it also brings the opportunity sometimes not to have to use a drill. So in most cases, I don't have to drill at all. If I do have to drill with a little bit left behind, it's very minimal. So it definitely improves my patient's experience. It's very ideal for pediatric patients, especially the young, anxious ones or special needs patients. You know, a lot of special needs patients can't handle the noise of the drill. They have sensory issues. So this is a great way to treat them. It can be used for atraumatic restorative treatment, selective caries removal. I've also found that using it in buccal class 5s has been really helpful, because I find sometimes when I use the drill, I stimulate, you know, maybe accidentally stimulate the gums, which then creates the heme, which is the blood. And it makes it harder to isolate the tooth and restore it properly. So using the Papacáries, reducing the use of the drill, I have a lot better isolation in my buccal class 5 cavities. So the steps for the procedure are actually very simple. You would isolate the tooth however you choose to, whether it's a cotton roll, rubber dam, or a dry shield. I prefer cotton roll or dry shield just because the rubber dam is uncomfortable. And usually with the front anterior teeth, I can get away with just doing a cotton roll. I apply the cotton pellet on the area of the decay that's exposed, and then I will leave it there for about 30 to 60 seconds. You should see that the blue solution turns a little cloudy, and that indicates that the enzymatic reaction worked. After that, you can take it off, clean the area, and then start removing the softened tissue with a spoon excavator. You'll see that it becomes a lot easier for the decay to be removed with the spoon excavator, and it's really quick. If there's still more decay left, you can repeat if necessary. If you're not getting the cloudiness when you apply it again, it usually means that it's kind of done. It's done its job. So I would just then either check if you're ready to restore, or if you want to do a little bit of minimal drilling in the area. Then you can restore it with a glass ionomer or a composite. So this is an example of one of my cases. This was a 3-year-old uncooperative boy. The patient could not even tolerate x-rays. As you can see, he had decay on the mesials of E and F. The couple options that were presented were sedation and treat the patient with strip crowns or zirconia crowns. Second option would be SCF application, which, as most of you know, will leave the patient with significant staining in most cases. And the last option would be to restore in office using Papacárie Duo and doing a final restoration with no sedation, nitrous, or any anesthesia. So the parents went with the third option, which I pushed for because I felt like it was a very good case for Papacárie Duo, especially since the decay is exposed. So it'll be very easy to apply the Papacárie gel there and remove the decay. So the Papacárie was applied to the exposed area of the decay. I put it on a cotton pellet for about 60 seconds. Then I used a spoon excavator to take out the softened decay. The decay became soft, leathery, very easy to scoop. Then I restored it with a composite. I used the one-step bond by Papacárie's Adhese Viva pen, and then I used beautiful composite. Alternative would be to restore with glass ionomer as well. So up to clinical preference. As you can see, it looks fine. Patient sat through it. There was no issues. Parents were very happy. There was no drill that had to be used in this case, which, the parents were kind of surprised and confused at the same time, but they were very happy that, the treatment could be done in office. They didn't have to worry about any kind of sedation or their child getting any local anesthesia as well. So as I discussed, the benefit in this case was there no handpiece was used in removing the decay. It was a much faster working time, especially since the patient was 3 and uncooperative. I had to move pretty quickly, and the parents were extremely happy with the aesthetic result and the behavior of the child. This is my second case that is about a 5-year-old male. This patient was referred from a general dentist. The area that I'm going to show that I did the caries removal was S and T, where there was significant occlusal caries, and you can see that they were exposed in the picture. I'm going to be showing you a video on the process. So this 5-year-old had occlusal caries on S and T. As you can see, they're pretty exposed, so it was a great case for Papacáries. I dried the area. I put Papacáries on with a pellet and kind of just soaked it into the area of the decay. So you can see how I just create a cotton pellet, put the Papacáries on, and then kind of stuff it in there. And then I leave it there for about a minute. After the minute I take the pellet out, I dry the area with the dry pellet, rinse out any Papacárie that may be left. And then I'm going to take a spoon excavator and start excavating the decay, which becomes really soft and leathery and really easy to scoop after the Papacárie application. So I'll continue to excavate as much as I can. I checked the preparation with an explorer. In this particular case, I did find like a little bit left on the margins that I wanted to just clean out. So I just went in with a slow speed, very quickly, very minimally, and then just confirmed that everything was solid. And then I was ready to proceed with doing the actual composite filling. In this case, I used a one-step bond with a dry shield and cotton roll isolation and just a beautiful Filtech composite. The benefits in this case was there was no local anesthesia that needed to be used. There was no sedation. I used minimal drilling at the end. The patient experience was absolutely excellent, very cooperative because it wasn't a very scary thing for the kid. The kid also had 4 other areas of decay, which I was able to treat in the same way on this, and the patient was very well behaved, and the parents were really happy that the child's behavior was great and that we completed everything in one day. So they were referred, and then I did the treatment that day, and he was all set to go back to his general dentist. So it was an excellent experience for the family. And keep in mind, since I am a pediatric dentist, I was able to do this case, but this is a case that a general dentist may be able to do using Papacáries, especially if a patient is very cooperative. And the Papacáries makes the experience better for the child. So I do find the children who wouldn't be cooperative with a drill are going to change their behavior using the Papacárie because it's a lot less scary to them and there's no noise involved in removing the decay. So the benefits Papacáries presents to patients is it's pain-free caries removal. There's no anesthesia in most cases. It reduces the fear of their dental visits, and it has much higher acceptance among the children and the parents when it's presented. The benefits to dentists is it saves time compared to traditional drilling in most cases. It's very minimally invasive. It also helps build trust with families because of the minimally invasive approach. This enzymatic solution can honestly really change things for underserved populations or people that go on mission trips where they may not have access to drills. They can use the Papacáries and remove more decay than they would have before. I personally have gone on a couple of mission trips, and I know that there's a lot of limitations when you are bringing things from the US to these places. And I think Papacáries is like one of the best tools we could probably bring when we're going on those mission trips and serving these populations. It supports preventative and conservative care models, which, as most of you know, that's the research is showing is better for the tooth. The more conservative, the less invasive we can be, the better it is for the longevity of the tooth. And the price of Papacáries is comparable to the price of one burr. There's about 20 applications in one syringe. So it's very affordable, and it's definitely has a huge advantage in treating the pediatric population. Clinical trials have shown comparable caries removal with the Papacárie compared to drilling. If you were to do a PubMed search on this product, there's over 100 studies present in the market. So it's definitely been heavily researched, and even though it was just brought into the US last year, it's been used across the world for over 20 years. There's definitely less discomfort and anxiety that the patients report, and the studies have confirmed that it does preserve the healthy dentin, and it has a lot of positive acceptance by pediatric dentists who are using the product. The limitations and considerations when using Papacárie would be, very deep lesions or possible pulp exposures wouldn't be appropriate. You may require multiple applications. I personally have found that it works really well, even just doing it one time. In my experience, I haven't really had to reapply it, but I know obviously that would depend on, the extent of the decay in the tooth. It may be a little slower than drilling in large carious lesions, but I think that's very case dependent. And it is best for small to medium cavities. And the final limitation is you need direct access to the decay to use it. So sometimes if you don't have that direct access, you may need to drill into the tooth a little bit and then apply the Papacáries, which I have done on young children, where I drill a little bit with the slow speed, I then use the Papacáries, remove with a spoon excavator, and then restore. It's still a very successful appointment because I'm using the drill much less than I would if I didn't have the Papacárie. So how do you integrate this into your practice? Train your staff on the way you want to apply the Papacáries, as I discussed before, how I use the cotton pellet, but you can absolutely use the microbrush. I keep a timer out so that I know exactly how long the Papacárie's been sitting on the tooth. Educating the parents. So when you have maybe a young patient that needs this kind of treatment, educating them that this is a solution, that is a kind of new technology. Parents love to hear people doing new things that are beneficial for their children, especially hearing that they may not need to drill, or it might be only for a few seconds. That's a big sell to the parents. They're very happy hearing that, because all they want is their child to have a good experience at the dentist. So it's good as an alternative. As you saw in my first case, there was 3 options, and this was the option that me and the parents chose to be the best, and it was a success. And then just pairing it with other preventative strategies, sealants, fluoride, other things that involve, minimally invasive dental care. I think whenever you present that to a parent, they always prefer that. And in any medical or dental field, like less is more to people. They will always prefer that. So Papacárie supports our minimally invasive, patient-friendly dentistry, extremely effective for pediatric and anxious patients, and especially some of your special needs patients. It's backed by research, and clinical experience has shown that it is a very effective tool. I highly recommend adding it to your caries management toolkit. It's been a game changer for myself when it comes to these young patients, that I can now offer something to the parents that isn't always just sedation or SDF. It's an alternative that they can choose from. So it makes you also look better as a clinician, that you're up to date with all the newest materials and alternative options you can offer to your patients. So I'd like to open up the webinar to our Q&A session. If you have any questions, please put them in the chat, and myself and Dr. Jurgens would love to answer any of those. Thank you.